Good evening to all of you. Interventions in aorta arteritis, particularly in specific for the arch vessels, is in this session given to me. As an introduction to aorta arteritis, we all know it's a chronic inflammatory disease of unknown etiology, and it causes stenosis, occlusions, and rarely aneurysms in its chronic phase. After the acute phase with raised ESR and other clinical signs of acute reaction. And it involves mainly the aorta and the large branches of the aorta typically, and this pathology typically differs from atherosclerosis, and that is very important when we consider the management by endovascular therapy. And aorta arteritis causes marked thickening of the intima and also the adventitia, and it causes extensive fibrosis of the media, which is typical in its pathology, and which marks the difference in the management by endovascular therapy. What are the treatment options that are available? One is the medical therapy, which includes steroids and other immunosuppressive therapy during the acute phase. And even during the acute phase, when the symptoms are refractory, like it was said in one of the earlier discussion, one should not wait for the symptoms to regress or the reactivity to subside. We may have to intervene even during the reactive phase when the symptoms are refractory to medical therapy. And surgery is the next option. Though surgery is quite difficult in aorta arteritis, in view typically of its very long lesions involving very long segments of the aorta, starting from the thoracic aorta extending to the descending the abdominal aorta, it becomes difficult for the surgeon to expose both the thorax and the abdomen. And because of the extensive fibrosis it causes, it's also difficult for the surgeon to land a graft or even do extensive dissections of the fibrous segment. And finding a disease-free segment to land any graft in the long disease aorta is difficult. So surgery is actually a very difficult choice, and hence endovascular therapy becomes important. And when we can consider endovascular therapy, the facts that have to be kept in mind, unlike in atherosclerosis of any stenotic lesion, is the disease activity, whether one should intervene and when the disease is active or not, and whether the lesions, because they are very resistant to balloon dilatation, and typically they involve very high pressure dilatation, inflations are required to break the lesion open, unlike in atherosclerosis, and this has to be kept in mind, which can cause potential problems, and hence cutting balloon comes as a handy choice, particularly in aorta arteritis. And because of high pressure dilatations, one can end up with a vessel which actually has ruptured in your hands, and sometimes because of the poor inadequate dilatation after the balloon dilatation, pre-dilatation is done. When you expand the stent fails to expand, and we have had problems of coming out with an unexpanded stent in one of the major arteries. And the extensive lesions, it becomes difficult to treat very long segments of the disease, and also the restenosis rates are quite high, and it can be quite disgusting. And the interventions, particularly when it involves the supraaortic vessels, which is topic of today, is typical involvement of the subclavian artery. It can involve bilateral subclavian artery, particularly in the first segment before the vertebral artery takes off, and also cause long occlusions of the mid segment of the subclavian artery. And typically all the multivessel involvement of the arch vessels are very common, and that may have to be kept in mind when we do arch vessel intervention, unlike in atherosclerosis, which typically involves a bifurcation of the carotid and doesn't involve both the carotid and subclavian at the same time. Very rarely we see such lesions. And the strokes and other ischemic symptoms which results in aorta arteritis are typically due to hemodynamic compromise because of the tight stenosis rather than embolic strokes which occur in atherosclerosis because of artery to artery embolization. And this also was discussed some time back. The protection devices are not so useful, or it is not required when you do balloon dilatation of the carotid or subclavian, because it doesn't very much embolize. And one may have to intervene even on only one vessel of the arch vessels, which is providing the sole blood supply, which was shown some time back in one of the talks, and I will also exemplify that. And when you open the stenotic lesions involving the multiple arch vessels, one may end up with a hyperperfusion syndrome, like you may open a tight carotid stenosis on one side and open another tight stenosis of the vertebral artery on the other side, which one of the carotid arteries which are occluded, which will result in hyperperfusion syndrome, and patient can land up in coma. That has to be kept in mind before you do a staged procedure on the patient. And so you may have to consider a staged procedure for opening the vessels. And here is an example of an extreme cerebral ischemia in a very young lady. She's a 32-year-old lady who presented with claudication of the right upper limb for the last 3 years, and she had recurrent TIAs involving the same left hemiparesis, which would recover within a few hours. And frequently she had lightheadedness and near syncope in the last 1 year. On examination, she was found to have no pulse on the both upper limbs, and both carotids were also not felt, and but both the lower limb vessels were normally felt, and the blood pressure was not recordable in the upper limb, and the lower limb blood pressure was normal. And she had a bruit in the right carotid, and both the subclavians also had a bruit. This is an arch angiogram of the patient. You can see that there is a significant stenosis of the innominate at the end of the vessel, and the right carotid artery has become almost like a string, and it's very long, tight stenosis of the right common carotid artery. And after the common carotid takes off, the subclavian has got a tight stenosis before the vertebral artery. And you can see one of the arch vessels is missing, the left carotid artery is gone, it's totally occluded, and the left subclavian artery shows a tight stenosis in the proximal segment. This is a typical involvement in aorta arteritis, involves very often all the 3 vessels. And it's quite challenging to treat it. We decided to do the angioplasty of each vessel in a staged manner. This is a diagrammatic representation of the left subclavian artery showing a tight stenosis before the vertebral takes off, and the vertebral artery is actually normal. She developed, after doing the angiogram, she developed weakness of the left upper limb and left side of the face after 18 hours after the angiographic study, which was not related actually to the study, and she recovered within a few minutes. And there were few other episodes in the next 2 days in the hospital stay. So what are the issues to be considered when we intervene in this patient? The patient is having symptoms and you need to intervene. What is the disease activity? Can we wait to do the intervention? And which lesion is to be treated first to avoid the complications? And the risk of having hyperperfusion syndrome? And how far do we go and open all the vessels? The ESR at the time of admission was 47 millimeters per hour, and she was put on prednisolone 1 milligram per kilogram per day for 2 weeks. And we saw the ESR at the end of 2 weeks was 26 millimeters. So we decided to intervene in this patient because she was symptomatic in spite of the activity. We did the first left subclavian angioplasty. We used a 5 into 20 millimeter peripheral balloon and dilated for 1 long minute at 8 atmospheric pressure and deployed a Palma stent 6 into 40 millimeters. You can see the stent in the proximal subclavian. This is the result after the subclavian angioplasty with a good vertebral flow. And then we decided to do a right common carotid after 24 hours. We gave a break and then took her up again in a staged manner. Wires were placed both in the right subclavian artery and in the right carotid artery. Coronary balloon was used to do a serial dilatation because the right carotid stenosis was very tight and we couldn't take a peripheral, we didn't think we could take a peripheral balloon initially. We used a 2.5 followed by a 4 millimeter coronary balloon. Finally, we used a 6 millimeter peripheral balloon to end with the procedure. And we deployed a long self-expanding stent, wall stent, 8 by 70 in the carotid artery starting from the innominate. And this is the result after the angioplasty. And after that, we stented the right subclavian at the origin using a Palma stent again. This is the final result after the angioplasty of all the vessels. Now we have a good vertebral flow and carotid and the right vertebral flow. So this is somewhat similar case is another small boy who presented with a lot of symptoms and he almost had recurrent syncope. You can see the arch aortogram showing only one blood vessel to the whole brain, and that was the left vertebral, and the left carotid is gone, innominate is gone, and there's a tight stenosis at the origin of the left vertebral, and also the aorta adjacent to the vertebral is tightly narrowed. So we did a kissing balloon angioplasty, kept a wire in the aorta and one in the vertebral, and did a simultaneous balloon dilatation of both the aorta and the vertebral, and this is the result after the angioplasty. He did have a near syncope on the table during the balloon dilatation. We did a very quick inflation and deflation and repeated it again after giving some perfusion to the brain, and that was the final result. And when we consider the long stents in the carotid artery as we saw in this patient, I also mentioned that is associated with a high incidence of restenosis in the arch vessels in aorta arteritis. So that is to be kept in mind when we look at the long-term results and what else can we do to prevent the long-term restenosis. So now we have peripheral cutting balloons, which is typically very useful in patients with aorta arteritis. because it causes extensive fibrosis which are very resistant to balloon dilatation, and we need to end up using very high pressure balloon dilatations, or you in fact use even a larger size balloon, and the risk of vessel rupture is there.
Your time is up. You are told 10 minutes. Because the afford will be sitting here till 10 o'clock at night.
Okay, sir.
We said strictly 10 minutes is 10 minutes.
Okay.
Just wind it up quickly.
So cutting balloon angioplasty, you can achieve avoiding putting in a stent which is associated with restenosis in aorta arteritis. So angioplasty of the arch vessels in aorta arteritis is not comparable, or it is not the same ball game as in atherosclerosis. All this while we were discussing for carotid angioplasty. We need not use a protection device, and we need to do a staged procedure and keep disease activity in mind. And also we can try to avoid using stents because it's associated with higher incidence of restenosis by using a cutting balloon angioplasty and obtaining very good results, immediate results. And in fact, Dr. Michel also mentioned about the long-term results are also quite good with cutting balloon angioplasty.
Thank you very much.